Welcome everyone to our next session of the plenary. It's my pleasure to introduce you to our interactive experience with virtual reality. Virtual reality is a term that conjures up many strong images, perhaps of video games or futuristic movies, or of people wandering around with helmets lost in an imaginary world only they can see. But there's so much more to this technology than playing video games, and we're going to give you a taste of that as it has entered our professional lives today, really only touching the surface of what is possible. Surgical Theater is an innovative company that has brought virtual reality to the surgical arena, developed by flight simulation technology, and has focused its initial applications to micro-neurosurgery. This is principally centered around use both in the clinic for patient education as well as in surgical planning in the operating room. Dr. Peter Nakaji from the Barrow Neurologic Institute and myself will moderate this morning's session, wherein we will delve into preliminary groundbreaking work currently underway and which is frankly ready for prime time by bringing you examples from the clinical world using the experiences of our surgical leaders on stage with us today. The first two speakers will introduce the concept of virtual reality, and you will be able to see what Drs. Warren Selman and John Golfino see on the screen behind us. We will save the interactive VR experience for our last speaker, Dr. Neil Martin, so you will not be able to use your phones until he speaks. It's my pleasure now to introduce Dr. Warren Selman, our first speaker, Chairman of Neurologic Surgery at University Hospitals of Cleveland.
Thank you, Nick and Peter. Thank you, ladies and gentlemen. So I'd like to start by showing you the case of a 47-year-old man who presented to our hospital with subarachnoid hemorrhage from a pericallosal artery aneurysm. But before I do that, I want to really set the stage for you and show you how really, as Nick talked about, this immersive technology helped change the way we cared for this gentleman. So you're going to see on the screen behind me the standard views that we use when looking at anatomy from the patient's images on a CT angiogram. But I want to first start out by saying and remind you what Michael Jordan said when talking about improvement. He said, no matter how good you are, always keep working to improve your game. And I think that's really what we're going to talk about today. How can we improve our game? So I am from Cleveland, obviously, proud of the Cavaliers. And if we stick with the basketball theme, Coach Bobby Knight said, the key to success or winning is not so much in the desire to win, because everyone has that, but it's the desire and the will to prepare to win, to prepare for success. And how do we get that preparation for success? Well, nothing is more important, actually, than visualizing that success. So really keeping that in your mind. So if we think about elite athletes, everyone knows that they really visualize what they're going to do to succeed. But if you're tired and had enough of all the sports analogies, remember that over 100 years ago, Henry David Thoreau said, the key to achievement is to keep a picture of success in your mind. And I'm going to show today how that virtual reality will allow each of you to get that picture of success. So again, I'm going to start by presenting the case of this gentleman and show you here is the anatomy that we had with the CT angiogram. It's what we're all used to looking at. It's the three plane views that we see, and it's very helpful for getting an idea of where the aneurysm is. But if you give me a second, I'll put on the goggles and show you what that image can be transformed into. So this is taking that patient's same anatomy that you got from the DICOM images, and now what we're doing is actually looking at a view of the patient's skull, and you can see the aneurysm before me. And what I'm going to do is take you through the surgical corridor. I'm going to fly in along the surgical corridor, which is the purple lines that you see, and bring you closer to the aneurysm. Now this is the surgeon's eye view, and it's very helpful for getting an idea of what you're going to see through the microscope. But what I want to show is different about what we can do with surgical theaters. Not only can you see the anatomy in front of you, but you can see what is behind you. And that simply isn't possible in any other way. So I'm going to look around and now you'll see that I'm looking at the back side of the aneurysm. I can get a view and know that not only will we have to deal with what we can see, but we'll have to deal with what we can't see. And this allowed us to plan for our surgical approach in a way that wasn't possible before. So looking at that, we figured we would start with a right angle clip that would allow us to secure the top of the aneurysm. And as you can see, this is helpful for getting that portion, but we knew we'd have to do something to deal with the backside of the aneurysm. So surgical theater allowed us to plan for the approach by using fenestrated clips and then successfully execute that plan that you'll see here. So now the clips are in place, and what I want to do is show you again what that looks like now from the backside. And you can see we're able to secure both sides of the aneurysm. So is this just a video game, as Nick pointed out? Not really. This is actually how reality looks. So I'm going to show you what this turned out to look like at the time of surgery by using what you actually see at the time of clipping. So the surgeon not only rehearsed what he was going to do, but was able to actually execute on that. And this again shows the clips going in place just as we rehearsed. And now you can see the final clipping. The aneurysm is secured and all the vessels are intact. So again, we were able to plan and then execute on the basis of this. So I think you can see I'm going to take the goggles off now, but I think this allows us to do exactly what Michael Jordan said, and that is to always keep working on our game.
Warren, have you found that this technology can be used for preparation of surgery for any other ways?
Well, in fact, it can, Nick. What we've found is very exciting is that if you think that it's important for us to be able to see that, it's actually more important for the patients to be able to see that. This is where technology is not driving a wedge between physician and patient. It's actually bringing us closer to the bedside, because when the patient puts on those goggles, the old statement is really true. A picture is worth 1,000 words. It just doesn't do justice to how engaged the patients are. And in fact, we've received funding to look at this in a larger group of patients to see how well we can interact and improve actually patient engagement with the use of this technology.
Well, thank you, Dr. Selman.
Thank you all for your attention.
So let's turn to Dr. John Golfinos, Chairman of Neurosurgery at NYU. And again, what you're going to be watching for this segment is up on the big screens, not on your phones yet. But if you haven't downloaded the ST360 VR app, you need that and the glasses for the next part. So, Dr. Golfinos, how is VR more than just pretty pictures? How does it really impact the patients?
Well, so that was, I was trained by Patrick Kelly, and Patrick would look at some of these things and say, well, that's just pretty pictures. How's it really going to help us? And that's the difference. This is real virtual reality. This is really rehearsing a case before you get to do it. So I'll show you a difficult case. I always don't like when people show you a new technology and they show you some trivial case like a convexity meningioma and say that it really helped them. This is a much more complicated case. And this is a middle-aged gentleman, and I got the goggles on now, so you should be able to see the MRI behind me. And he's got a right posterior thalamic cavernoma, which you should see right on the screen. And the issue was that he went around. He had the means to go around to several places. He got several different opinions, and out of those, you can see the lesion right here, right? And out of those different opinions, then. He came to us. And so Howard Rena, actually, who saw the patient, said, John, if you can just get me there, I can take it out. And I said, Howard, I'm going to get you there. So we actually looked at the different trajectories that had been proposed at other institutions and some very well-known places, and people wanted to come in with lateral trajectories. But the problem you can see is in blue, the corticospinal tract, and then also inferiorly the optic radiations. And those were going to be critical for us, and that's what we wanted to see. So we ultimately came up with a superior parietal lobule approach, which will be the approach that you'll see next. And using the surgical theater, we're able to actually rehearse this case. So now I've switched you, so we're looking back. We're at the patient's back. This is how we actually positioned the patient in surgery, so they were sitting straight up, so the nose was away from us. But the critical thing is we can see the actual veins that we're going to use, and this allowed us to plan the cortical incision right here using an elliptical retractor to get us down to the down into the ventricle. And this was the virtual reality, and I'll prove it to you because here's a video that shows you the reality at the time of surgery. There's that vein exactly, and we put our incision right where we had seen it in virtual space. Now you're seeing it in real space. So we actually rehearsed the case ahead of time. And it allowed us to look at all those other trajectories and then pick this one as the one we figured was going to be the best. That's the elliptical retractor going in now. As you can see, it'll come up a little closer. Okay, so now here's our corridor, and I'm now flying you right down the corridor, and we're looking for the ventricle, and you see it in front of you. So I can see that my retractor is going to come down, so I see the lateral wall of the ventricle. Here's my virtual pointer. Lateral wall of the ventricle over here, and choroid plexus was down to my left, so you can see that. And as we look at the video, this is in real, obviously there's a video we've overlaid, the real video of entering into the ventricle. And now as we enter into the ventricle, the question becomes, well, where is the thing? But there's no time to panic now because we've rehearsed all this. We know where it's going to be. We see the choroid plexus down there to the left in the corner over here, and we know that this is the groove between the posterior thalamus and the lateral wall of the ventricle where we're going to enter to find the real lesion. And here's the virtual reality that we used to practice that, and that was the choroid plexus. And the best part is we can ghost the virtual reality to know that the tumor is going to be the cavernoma is going to be right here in front of us. So it becomes a situation where I tell my colleague Howard Arena, I got you there, Howard. Now all you have to do is just cut here because we've seen it before in the virtual space. And so now the best part is we can also even go down past it, and we can look back. Once we're past, we can look back up and see where we came from. And that's that's the entire approach there that you can see. And you can see that finally, so it's really, if we play the video now, you'll see the actual resection, and it's where to cut. And the cut was exactly where we planned it to be. You can see that choroid plexus was down there, and that was where we made the incision here. And then the other thing that's important is that we saw the tracks in front of us. We know that they're away from us, so we were able to avoid both the corticospinal tracts and the optic radiations below us. So it makes a much safer surgery, and that's the actual cavernoma coming out. Howard did a great job on this and pulled it straight out. But the difference is it really enabled us to plan out the different trajectories and see which one was the best one for the patient. And the interesting thing is you had a lot of very well-known institutions looked at this, and everyone disagreed, on what's the best way to do this. But that makes a big difference to us, being able to actually rehearse that case and rehearse each of the potential trajectories, the lateral versus the superior parietal lobule approach, all the difference in the world for us. So it's a real tool. We use it on every case, and we use it more on the difficult cases than we do on the simple cases, obviously.
John, what other kinds of cases have you used it for?
Skull-based meningiomas, where you're looking to see which arteries are buried in it, especially a clinoidal meninge. You know that the carotid and the optic nerve are going to be medial, but where are they? So it's great when you can actually walk through that and rehearse it and see the arteries, know where you're going to run into them before you're there in the surgery.
And have you ever used that to explain this to a patient?
I'm sorry?
Have you ever used that view to explain it to a patient, why you're choosing it?
It's got to be the rare, not rare, but it's got to be the tech-savvy patients. I think, as Warren said, the younger ones are really ready to see this, and you watch them, look at it and get it instantly. And, they'll say to you things like, wow, that artery really is awfully close, isn't it? So they get a real appreciation for what we do, I think, and what the surgery means.
All right. Thanks, Dr. Golfinos. That was great. We have Dr. Neil Martin here, Director of the Neuroscience Institute for Geisinger Health System. So this is the time to start getting your 360 VR app and your glasses ready. And so I gather this is the exciting part. We get to try to set a Guinness World Record. But can you put it all in context for us?
So now's the time to get your glasses out and get them ready. We're going to ask you to put these glasses on your phone because you're not just going to passively watch me explore a case in virtual reality. You're all going to do it yourselves. So you're going to put this on your iPhone. You're going to launch the ST360 VR app, and we're all going to see the same trajectory through a case. We're going to take a look at a case of a patient with an intracerebral hemorrhage. So what you've seen so far are exciting case reports of the next generation of neuroimaging. No question in my mind about it. There was just an article in the MIT Technology Review that came out a couple days ago that one of the headlines is Microsoft is all in on virtual reality. I encourage you to take a look at that. We just heard from the futurist in our previous talk how things are changing very, very rapidly. So these case reports you just heard, I think, are going to replace our traditional paper and color image case reports that we've been used to seeing throughout our career. We're going to now explore in virtual reality case reports that integrate the fusion of multiple types of imaging and intraoperative video, as you saw in those last two cases demonstrated very nicely. What we're approaching now is an entirely new generation of neuroimaging, of surgical simulation and rehearsal, of flying the mission ahead of time before you get in there and you start doing the surgery itself. What is this offering that we don't get in traditional neuroimaging? These reconstructions you're seeing are constructed from the same kind of images we use for intraoperative image guidance. These are thin-cut CT scans, CT angiograms, MRI scans of various sequences, and DTI, and they're fused together in one volumetric three-dimensional image that you can cut and slice through and see the internal structure of everything. You can segment the individual types of anatomy, so the scalp, the skull, the brain, the veins, the arteries, the fiber tracts, the tumor, all can be separated. Each can be manipulated. They can be rendered semi-transparent or stripped away entirely, one by one, until you see that critical anatomy that's necessary for you to plan the perfect operation. You know, what does it take to win the Super Bowl? Certainly it takes talent and skills acquired through lots of practice and lots of experience. But the winning team is the one that has the best game plan. And the game plan recognizes the opponent. For us, that's a cavernous angioma or an aneurysm or an AVM or a skull-based tumor, and recognizes the setting of the game so that you can set a game plan. When a battle is planned, you have to recognize the characteristics of the enemy, again, the lesion, and the terrain involved. The terrain involved is all the surrounding normal anatomy that we have to protect. So we have two jobs. We have to approach the pathology and eradicate it or correct it, and we have to design a trajectory that's going to avoid all of the critical structures that have to be protected, which is the essential thing, obviously, for the patient's great outcome. So this technique doesn't just allow you to look at it. It allows you to interact with it, to see the different layers, to fuse multiple images, and it gets you inside it. And so we're all going to get inside a cranium, and I'll let you know about the case here. This is a middle-aged patient who came in with a spontaneous hemorrhage. We weren't sure whether it was related to a middle cerebral artery aneurysm, and we weren't entirely sure of its exact relationship to the critical fiber tracts, and we wanted to know those before we went in and used a minimally invasive approach to take out the hematoma. So in just a second, you're going to take your glasses. You'll see the video on how to assemble your personal VR headset. You're going to take the glasses. You're going to clip them to the middle of your screen, just as you see in the video here. You have to launch the ST360 VR app now. I'm going to use a Vive headset that allows me to look around inside the cranium just as you will do on your phone, and you'll be able to interact with it independently of the way I'm looking at it, although we're all going to be on the same fly-through trajectory here coming up in just a second. So get your phones out. The countdown is starting now. And you should be seeing one. And here comes the video. We're going inside the cranium to see this intracerebral hemorrhage, which has been constructed from the fusion of a CT scan, a CT angiogram, an MRI scan. There's the hemorrhage. The blue is the surrounding edema. We see the vessels from the CTA. The yellow gold fibers are the corticospinal tract displaced by the hemorrhage. Look around, look up, look down, evaluate the anatomy, and we have to choose a trajectory. Where are we going to enter the hematoma? We can also see as we look at the CT angiogram that there is no MCA aneurysm there in the sylvian fissure next to the hematoma. So this is a hypertensive hemorrhage, and we will see all the fiber tracks here. That's the critical anatomy that we've got to avoid as we select an entry trajectory, probably something along the posterior or posterior lateral approach. And we also know we cannot suction in the area of the yellow fibers, the yellow corticospinal tract fibers, for fear of causing a problem. Now, we've also digitized a brain port. And so the brain port has been lined up on the appropriate trajectory. It's going to take us right to the hematoma, and we're going to use that tubular retractor to assist in the resection of the hematoma. Alternatively, we could use an endoscopic technique. So here we are seeing those cortical spinal tracts again as they travel along the hematoma. We don't want to suction there. We don't want to disturb them as we remove the hemorrhage. So that's the kind of exercise that we're all going to take. And I think we've certainly approached a record for the most simultaneous virtual reality experiences ever conducted anywhere by the size of the crowd, which is probably over the previous record of about 1,100. Certainly we've set a record in getting more than 6 neurosurgeons to be instructed to do the same thing and actually do it at the same time. So thank you all for your attention. And gentlemen, if you have any questions, I'd be happy to address those.
I think we're about at time, but I am very pleased to announce, although it has to be certified, we have broken the record with over 2,057 people. So
yes,
thank you, everyone. The most neurosurgeon VRs.
Thank you.